we are live. Welcome to DC2B Revolution, helping chiropractic students think big in order to live large. I'm your host, Noah Volz, and today I'm here with Dr. Carl Nottoli. He graduated from Palmer College of Chiropractic in 2012 and has been an integrative diagnosis provider. I'll usually refer to that as ID, since that same year in 2012. He's been an integrative diagnosis instructor beginning in 2016, and he's the owner of Functional Spine and Sport in Chicago, Illinois. Dr. Carl, thanks so much for being here.
Thanks for having me, Noah.
Yeah, my pleasure. So I really wanted to start with, what is integrative diagnosis? How is it different than all the other tools that out there? On the website, it talks about, how a lot of students, chiropractors spend money on these manual therapy programs that don't really give them what they need. And it says integrative diagnosis is different. So tell us what's different about it.
Sure. So we can first just start with what ID is. So from a just big picture standpoint, ID is a system that's for a complete diagnosis and conservative treatment management for musculoskeletal conditions. So essentially everything that we do in our scope of practice, whether you're a PT or a DC, or even a licensed massage therapist, that's essentially what you're going to see coming in your door, or conservative musculoskeletal problems. So that's what ID actually is and actually teaches. So what it's not is it's got detailed procedures and tests for everything you do in your office as a provider. So from the history to the functional testing, to the palpation of adhesion, to the communication, to the management of the patient, everything is built in a robust system.
Yeah, so it really sounds like it's kind of a protocol of sorts. You've been doing this for a long time. I've even heard of people having great results with your treatment. How much individuality do you kind of see in terms of your own practice of ID?
Can you clarify your question?
Well, I guess, like, if it's kind of a step-by-step protocol of how to do things, I'm wondering if it's like an algorithm where you kind of go through the step and it allows you to kind of think on your feet and figure out, what's really going on with the person, or is it pretty cookie cutter, I guess is the question.
Yeah, so not very much at all. We're trying to get it streamlined more to where it's more digestible, even for a younger practitioner or a student, to have more reliable testing, have more reliable treatment, have more reliable diagnosis. But inherently, patients are complex, and inherently musculoskeletal problems are complex. So there's a lot of individuality that comes along with that, and a lot of personal experience that goes into the training, but that can be said for any profession. The more diligent and focused work you put in it, the better you are at said profession. Professional athletics is an easy analogy for somebody to get. If you're a high school basketball player and you're great, you're still not beating Michael Jordan, even at this age, probably not. So there's a big experience component to that and time component to that training. But everything is built in the system to help you along the way in becoming more and more streamlined to make that more effective. But it's not, like you're saying, it's not necessarily a cookie cutter, because nothing in life works that way. But it gives you tools to determine what the diagnosis is, to determine what step they're on as far as conservative treatment, if they are in fact a patient for that, and really what priority is each part of that diagnosis and kind of where to start.
Yeah, so I don't know how much you can share. I know a lot of this information is proprietary. There's a lot of competition in the marketplace. But can you kind of walk us through, walk us through that algorithm a little bit, so that we kind of get a better sense of, if I was to do ID and actually become a member, what could I expect, at the end of that training what does it really look like?
Well, the bigger picture to your question is that the training is never done. So that's a common misconception among doctors, I think, in all fields. But since I'm a chiropractor, I see it a lot in my profession, is that when you graduate or when you take one course, you're automatically a master at it and you never have to take it again and you're proficient. And, your training's done and on to the next thing, so to speak. But that's not how this system is built. It's built to make you a masterful practitioner, and then you just build on that skill and sharpen the saw all the time, right? So that's part of the long game on your question there. The short part of that question, the short game part of the question is you have to have an idea of what the patient is actually coming in with. So ID teaches practitioners how to interpret data points with the history. So as far as the sex and age of the patient, that's important, because certain things can happen at different age groups and different genders. So that's important to know where you're starting from that perspective. Then you also need to know how to interpret quality, symptom quality, symptom location, symptom intensity, what's provocative, what's palliative, so you know what's loaded and what hurts and what's unloaded and what feels better. That alone can give you a ton of information to know if they in fact are a good candidate to start with treatment. You can have a pretty good differential even after that point when you really know how to answer those questions. You can really interpret that anatomy and physiology, and what those, it's not just questions and checking a box in school that you might do in the student clinic or that you might do to submit to insurance. It's everything the patient says means something, and it's our responsibility to figure that out. So that's part of what ID teaches just on the history part. So that's just one part of the equation, which is big. That alone can get you a long way. Secondarily, or next, I guess, would be the testing component. So once you kind of get an idea of what you're up against and what you want to assess, that's going to depend on the individual situation. But if a certain case comes in and you're suspecting local problem, so say, for example, a knee or an ankle, and after the history, you're not suspecting that it's coming from a bigger global, you would just literally assess and test that local tissue in that local joint and see what the status is of that area. If it answers your questions, if it's reverse compatible after that, meaning everything makes sense with what the patient told you and what you're testing, then you kind of have a good idea of what the diagnosis is, or a complete idea of what the diagnosis is at that point. If it doesn't, or it doesn't answer your questions, or it's not reverse compatible, then you can start looking above and below that area and testing that and seeing what else is involved here. So it's a huge list and it's a lot to do. And it is complex. So that's why it's an ongoing process of learning that and refining that and making sure that, again, the patient is not being hung out to dry, but not also leaving anything to chance, and making sure they get the right treatment.
Yeah, I really like how you walked us through that and kind of, showed how this system really helps you figure out exactly what's going on with that person so that you can apply the treatment that is going to help them the most and get them better. Because, in this field, want the best possible patient outcomes. I think that's really the goal. I wonder if you could talk a little bit about, obviously it's reliable. You've had great results with people. What research have you found? I mean, is this kind of a synthesis of a lot of different research that goes into ID to validate the different procedures, or, how are you using the evidence to really the practice of ID?
Yeah, exactly. So it's a synthesis of the research found to provide evidence for clinical use, right? Because research it guides clinical judgment, but it doesn't dictate it. So if we waited around until research proved everything that we do, nobody would be in practice, they would be in research. So essentially ID it's a clinical training program, not a research training program. So we use the information that's out there, the research that's out there, to determine if what we're doing makes sense, and is it, again, reverse compatible to why we're doing it in the first place, and does it objectively meet the results that we want for the patient, as far as pain score outcomes, functional mobility outcomes. You can name a bunch of other assessment forms that you might use, but ultimately just ADL outcomes. Simple ADLs need to be improved too. So there is a significant amount of research out there for that, if that is what you're asking.
Yeah, and I'm also wondering if you do present that in, you're teaching. Do you, how big of a part does that play into the whole system? I know there's this big movement of kind of evidence-based chiropractic, and like you said, I think it's better to think of it as evidence-informed chiropractic.
Exactly.
But I know a lot of people who are on that camp want to know what you're utilizing in order to determine that this is the most effective approach.
Yeah, so Dr. Brady is completely objective with all this. So if a research paper came out tomorrow that says, the use of straight leg raise as a test is garbage, we would, one, review it and make sure it's correct, and then change it right away. But every time we look at, straight leg test is a good example. It shows that it has very good reliability, inter-rater reliability. It shows that you can use a handheld inclinometer to get consistent, reliable results. It does show that it is poor at determining the differential diagnosis between the disc herniation and low back pain and all that. But again, that's part of the problem with research, is that the test subjects, the research subjects, are put into weird categories that aren't tissue and pathology specific. So if a patient is ultimately 100 different parts, how do you research that in one part? You necessarily can't. But when you take apart each one of those SLR utility research papers, you can find that it does still point us in the right direction, that it is a reliable test consistently. And it also does test for neural tension that were previously thought that it was hamstring stiffness, but now it's not, because there's research that shows that the hamstrings that aren't at all activated when the test, or when the level goes up and it stops, and they either have a symptom or the test just stops, and they aren't a patient that has a disc herniation, so they can't explain that necessarily, other than the fact that it's not hamstring stiffness. So we completely agree. The one part that's missing, again, which leads us to why we palpate and treat and find or look for nerve entrapment, is that specific pathology. Adhesion around a sciatic nerve could limit a straight leg test in the absence of a disc herniation, in the absence of hamstring stiffness, which isn't a real thing. That's a reliable test to use to get a differential and to hone in and diagnose completely what is important with that one test. To segue into that, there's plenty of research that shows that adhesion around a sciatic nerve is in fact real. It does exist, and it does respond well to care. These are surgical articles. And the patients have excellent outcomes. I mean, it's insane, the amount of pain reduction, the functional test scores that they're using with their whatever outcome scores they're using, and the narcotic use going almost down to nothing. I mean, that's incredible. And they're only treating one spot, and it's surgical. So it does create a lot of other problems as far as recovery. What else is going to blow up after that? You never know. So it's a bit reductionist, but it works. So, and even in their articles, the surgical articles, they're saying, if you can, this is a last resort thing. So whatever you need to do conservatively, because it's not their job, please do that first, essentially, before these patients have to come down this road. And that's essentially what we do. We fill in that gap.
Yeah, I think that's so important to think about how you've really kind of integrated yourself into that musculoskeletal algorithm and have really found a way to synthesize all the tests that are out there, find the most reliable ones and utilize those tests to figure out the specific area and dysfunction of these different musculoskeletal complaints, and then apply a treatment that ensures the best possible outcome for the patient. I think that's really unique, and I think that's what every chiropractic student and probably chiropractor. Can you talk a little bit about how ID may compare with other systems that are out there? Of course, I'm a student. I'm not aware of everything. I'm aware of ART and SFMA and the diplomate in chiropractic orthopedics. But I just wonder, in terms of the bigger picture of chiropractic, where do you really see ID fits?
That's a great question. I think as a big picture, ID essentially teaches the provider what we should have learned in school. Everything that we learn in school is, where do you apply said technique? And ID is the only system that I found personally, after all the training and searching that I did before I found it, that says, what is the diagnosis first? After that, we can have a conversation about what treatment best fits the patient. But until we get the complete diagnosis, we're not talking about treatment. We're not talking about techniques. So that's the biggest distinction. A lot of the things you just named are, where do you apply this technique? Or you just apply this technique, not even where. There's no assessment in some of those. So that's the biggest disconnect with students and also physicians, is that we're kind of ingrained early on that it's all about, what technique do you do? What do you like to do? What do you do in this situation? It's like, hold on a second. Let's take a step back and let's look at the big picture. It's not about us, the providers. It's about the patient, first and foremost. That's why we all got into this profession to begin with, right? Secondly, it doesn't matter what treatment we're talking about until we know what the diagnosis is.
Yeah, thank you for that clarification. I mean, it makes sense why it's called integrative diagnosis. You've really that system of diagnosis specific to the musculoskeletal condition, and optimize that so that if you're treating the right area and the right the right dysfunction of the tissue, you're going to get better results. Whereas if you're just if you've just got one tool, if you're just a Gonstead doc and this is you're really good at side posture, then you may not be getting all your patients if you're using that one tool, right, whatever it may be.
Or if you have a shotgun approach, that's also just as ineffective, or can be less effective than only focusing on one. So you can see how things can really start to pile up, and then you start asking yourself hard questions. Hopefully people do, like, why is this not happening? Or why am I not getting the results I thought I would? So yeah, absolutely.
Yeah, and then that's also, I think, important for the profession as a whole, right? Because if more people have these skills, if more chiropractic students have these diagnostic skills, they're going to get better outcomes, and that ultimately is going to build more public trust. So, what are like the best kind of next steps for a chiropractic student, a chiropractor who recognizes that their diagnostic skills could be improved significantly, and they want to kind of explore ID and figure out if that's the right diagnostic approach for them?
Yeah, I mean, as far as if you're in school, or you're a doctor and you're in practice and you're happy or you want to be better, ID is the step for you. Because if you're in the scope of practice allows you to do conservative musculoskeletal care, and you really got into this profession to help patients and give them the best outcomes and be the best doctor you can be, in my opinion, this is how you do that. So again, Dr. Brady is incredible at synthesizing this information and putting it together to be able to train other providers with this information and allow you to get really good results and really patient-centered results. And again, he's really been the only leader in any technique system or any school of thought that has been truly objective in my experience, in my opinion, because he does, go through the information, the research, the data all the time, with what we're doing in clinical practice and what other professions are seeing and doing and finding, and really can objectively change and improve this system right on the fly. He's not married to one thing. He's married to results. He's married to the truth. And he's really the only person that I found to be able to do that as well as he does.
Yeah, I mean, that's a really unique skill set. I think so many of us, the further we get into a system, the more we start just supporting the system at the expense of the patient outcomes because we're so married to that system. So that's pretty unique. Be objective, to take the latest research and integrate that and test it and figure out where it fits in, if it does fit in, and how it can help the overall system. You mentioned at the beginning of the interview that this is ever evolving. So as a student, where time is limited, finances are limited, what do you feel like is kind of the time and financial investment to get really good at a system like this?
Well, what's worked for me, and it may not be what you want to hear, is that the more I put into it, the more I get out of it. This system has paid me back in spades. I mean, it's literally, if I don't even know what I'd be doing right now if I wasn't doing this. Let's put it that way. So I was in your shoes not that long ago, and I was scared shitless, if I can use that phrase on this, because I really thought I had it figured out and thought I could diagnose and treat patients with all the skills and tools I had from what we were taught in school, plus what I learned outside of school. And then all of a sudden started sitting down and saying, well, wait a second, where do I apply each one of these treatments? And then I had to take another step back and okay, I guess I got to go out all these textbooks and figure out how to assess this patient first and then figure out where to apply this treatment. And at first I'm like, okay, I'm on to something. And the more and more I got into that on my own, I'm like, I have no idea what I'm doing. And I have no idea how I'm going to help this patient and where I'm going to start and how I'm going to confidently be able to tell them that I have their best interest in mind. They're going to see right through me. I'm going to be a fraud. So that was my big epiphany early on. And that's what drove me into this. That's how I found this. And ever since I did, and it answered all those questions, and it was a system that already had those tools in place, it just made sense to me. So the more work I put into that, and the more time I spent immersing myself in it, really just pays off. Because again, the more you can know this valuable information and this critical skill set, the better results you get, the better your practice is, the quicker your practice grows, the happier you are. I mean, everything in life gets better when your purpose is fulfilled, right? So if your purpose and your mission is to do those things, then you have to kind of go through that individually with yourself. If that's being met, you're going to have a hell of a life.
Yeah, completely. And, it really, I really appreciate your story and see how that return on investment was really, valuable to you. What is the investment cost? I mean, what are kind of, if they decide to go down this road and kind of get the minimal qualifications to really utilize this well, what could they anticipate?
Oh, that's a good question. I'd have to probably go on the website and look. I'm a little far removed from that at this point, and I apologize. I did not look at that data beforehand. I know that you can start looking online at some of the basic information, about, what is adhesion, some of the testing that we do and why we do it. You can get online for $24 a month. And then from there, there's graduated plans that allow you more access and more information. And really what that is geared toward keeping the people that want to be there, but also lowering the rate of or bar of entry to say, well, I'm just kind of interested. I'd rather just look at it first. I completely understand that, completely get that. So that's how that's set up. But you're not going to get very far if you're only doing the $24 a month. So essentially that's there to kind of get your mind going, try to get you to ask some different questions and maybe get some different questions that you already had answered. And then from there, you really start to figure out where you want to go as a practitioner, what you're trying to get answered from there, what you're trying to build as a skill set. And then those tiers are kind of built in from the online portion so that you can have access to anytime, anywhere now with mobile devices and everything. And then the hands-on training, we do, we do 8 seminars a year. We do 4 in the spring, and then we do 4 in the winter, fall. And we do levels, kind of level at a time. So it kind of makes it, again, more digestible. Each one of them is, again, on the face value, it looks like it's not a lot of information, especially if you come from an ART background where I've taken a lot of ART before I found AD. And, you're used to being there for 3 days and learning, 500 protocols. And you're like, oh, shit, this is, what do we really need to know? What do we really need to train and hone in on, from the testing to the diagnosis to the treatment? It's a little bit more hands-on related because we are there in person. So it is a little bit more hands-on skill building heavy, which it's meant to be. But essentially we have those split up throughout the year, repeating in the fall to make sure that if you did miss in the spring, you can take it in the fall. A lot of guys, what they're finding is when they double down and do them twice a year with the same level. So for example, level 1 in March and again in September, when they do that, the men and women that do that find that they get way better results because, again, you just continue to build on what you've learned. A lot of the old habits don't come back in. You don't get, complacent and lazy. But you can, again, you can learn a lot from as little as you want to put into it to as much as you want to put into it. I've, continued to push that envelope every year I've been in practice. And at no point have I come to a point where I'm like, yeah, I did it too much this year. It just hasn't happened. I've always returned a huge amount of, success or happiness or patient outcomes, like however you want to measure that. It's always matched my purpose. It's not just dollar amounts you get back out of it, but it's always met me right where I am the more I put into it. So when I guess if I hit that point, I can let you know, but I haven't hit that point. But I can assure you that everybody that's currently in the system and doing it, they would all tell you unequivocally that the more you do it, the more you get out of it. And it's okay to start small, but you want to build and gradually expose yourself and get to meet all these other amazing providers and learn from them as quickly as possible. Because that's how you're going to build the practice of your dreams, if you just immerse yourself as quickly as possible.
Yeah, what is it, that quote? Like, you're an average of the 5 people you spend the most time with. So
that couldn't be more true. Yeah.
If you're spending time with good people, then it's inevitable. So let's say, a student heard this interview today. They really want to get involved. They want to, really want to hone those hand skills, like you were saying, with the different seminars, so that they, really are on the path towards mastery. What's the best way to get more information to really start to put themselves into this system and, take it as far as you've been able to take it?
Yeah. So integrativediagnosis.com is the main website. That's got all the information that we just discussed on there in detail. He's also on Facebook as well. He's got an Integrative Diagnosis Facebook page. There's also an Integrative Diagnosis discussion group that you don't have to be an online member to join, so anybody can join it. And there's also interesting discussions on there. We often post research articles that kind of discuss what the current research is showing, what the big questions that they're asking. When you read conclusions, it's often interesting sometimes the stuff they find, but the stuff they don't find, but they're not asking the right question to then aid in the next paper. Sometimes they do, and it's really cool to see. They're like, yeah, this didn't make sense, so this would be our next evaluation, would be this said thing. So we do often post research articles on there and just discuss, and so it's very interesting on that standpoint to do.
Well, perfect. Well,
as far as hands-on, even a student could take a hands-on seminar. Now, I would suggest you're at least on the basics, so you can get some idea of that information before you show up, and you're not, jumping into the deep end right away. But it's geared for everybody to get started.
Yeah, and did you start as a student? I know that your graduation and provider credentialing was pretty close together. Were you taking classes when you were a student?
I was in my preceptorship, and Absolutely.
So this has been a production of DC to Be Revolution, helping chiropractic students think big in order to live large. If you like this video, please subscribe to the channel, leave some comments in the comment section below, and share it with your friends. And Dr. Carl, thanks so much for being here.
Thanks a lot. No, I appreciate it.